Euthanasia comes from the Greek for good death and has been defined as the active or passive cessation of life of the hopelessly ill, injured, or incapacitated with the goal of limiting suffering and exhibiting mercy. For the purpose of this debate, active euthanasia means the administration of a lethal dose of a medication by a healthcare provider, while passive euthanasia is the withholding of treatments or supportive measures such as feeding tubes to prolong a patient's life. It can also include physician-assisted suicide, in which a physician provides a prescription for a lethal dose of a medication that a patient can take at their discretion.
Autonomy is defined as the right of self-government or personal freedom. Every person has the right to make personal and private decisions about their own lives, defined in the American Constitution as the right to privacy. Since death is the most personal of all things, the individual should have the right to dictate when they die and in what circumstances they do so. To deny people the right of death by active euthanasia is to force them to do something that is against their will and may well prolong their suffering. Those against euthanasia claim that patients are often too affected by their illness to make adequate decisions about their future, but this denies them their true autonomy because every decision that is made, regardless of the context, is always influenced by internal and external factors. If society recognizes the autonomy of individuals by granting them the right to pursue their views about the good life and create their own lives, then the logical consequence is to allow people to decide their own death. Death is a private matter, and if you are not hurting anyone else, the state should not interfere. The right to life is no more than a right. The right to life is not a duty to live. The right to life does not demand that it must be exercised. In the United States, courts of appeals for the Second Circuit stated in the opinion from Quill and Valco, it seems clear that New York does not treat similarly circumstanced persons alike. Those in the final stages of terminal illness who are on the life support systems are allowed to hasten their deaths by directing the removal of such systems, but those who are similarly situated, except for the previous attachment of life-sustaining equipment, are not allowed to hasten death by self-administering prescribed drugs. What interest can the state possibly have in requiring the prolongation of a life that is all but ended? And what business is it of the state to require the continuation of agony when the result is imminent and inevitable? What concern prompts the state to interfere with a mentally competent patient's right to define his own concept of existence, of meaning, of the universe, and of the mystery of human life, when the patient seeks to have drugs prescribed to end life during the final stages of terminal illness? The greatly reduced interest of the state in preserving life compels the answer to these questions: none. The American Civil Liberties Union, in its amicus brief from Vaco versus Quill, stated the right of a competent, terminally ill person to avoid excruciating pain and embrace a timely and dignified death bears the sanction of history and is implicit in the concept of ordered liberty. The exercise of this right is as central to personal autonomy and bodily integrity as rights safeguarded by this court's decision relating to marriage, family relationships, procreation, contraception, child rearing, and the refusal or termination of life-saving medical treatment. In particular, this court's recent decisions concerning the right to refuse medical treatment and the right to abortion instruct that a mentally competent, terminally ill person has a protected liberty interest in choosing to end intolerable suffering by bringing about his or her own death. A state's categorical ban on physician-assisted suicide, as applied to competent, terminally ill patients who wish to avoid unendurable pain and hasten inevitable death, substantially interferes with this protected liberty interest and cannot be sustained.
People with terminal illness who are suffering feel like they're more of a burden to their family members in their final stages of life, rather than feeling like a person being loved and cared for. By being able to end life without the final stages of severe suffering, this can create the total human happiness, not just for the patient, but for the family and the medical staff involved. Euthanasia can shorten the grief and suffering of the patient's loved ones. Rather than making the dying process a long, drawn-out process that can cause so much severe suffering and stress on the family members, it can be a short, pleasant experience for the family as a total. By justifying euthanasia, it allows people to have a more pleasant death at the time of their own choosing. This in return will make them happier than the pain that the illness may cause, that the loss of the dignity they may experience, and the distress of anticipating a slow, painful death. Patients with degenerative progressive illnesses often fear a gradual loss of quality of life in the future as the disease or disorder progresses, or they may have already felt a loss of a good deal of their independence and therefore might require continuous care. In addition, medical costs can be very expensive in the final stages of life. Patients suffering do not always want to diminish their assets by creating large medical costs as their death approaches. They ought to have the option to die sooner and pass on these assets to their loved ones or other beneficial sources. This allows them to feel that their life was worth something more by being able to leave something behind that might benefit other people. Disease can kill people in far more cruel ways than death that a physician might be able to provide for an irreversibly ill patient. So physicians providing euthanasia would be compatible with a physician's duty to the patient. Americans should enjoy their right to be forced not to suffer. It should be considered as much of a crime to make someone live who, with justification, does not want to continue living as it is to take life without consent.
There have been many studies in the last 15 years which show that healthcare providers in the U.S. are already assisting patients to die. For example, from the 2003 New England Journal of Medicine article, a national survey of physician-assisted suicide and euthanasia in the United States, Diane Meyer, MD, Director of the Center to Advance Palliative Care, et al., wrote, 11% of physicians out of 1,902 total said that under current legal constraints there were circumstances in which they would be willing to hasten a patient's death by prescribing medication, and 7% said that they would provide a lethal injection. Since entering practice, 18.3% of the physicians reported having received a request from a patient for assistance with suicide, and 11.1% had received a request for a lethal injection. 16% of the physicians receiving such requests, or 3.3% of the entire sample, reported that they had written at least one prescription to be used to hasten death, and almost 5% said that they had administered at least one lethal injection. It's better to bring it out into the open and allow patients to choose how to die, and for healthcare providers to be able to assist them without fear of losing their licenses or going to jail.
It is true that everyone has the right to die and the choice to make their own decisions, but in this country, murder is illegal, and thus a physician administering a lethal injection is illegal. Everyone has free will and can make their own decisions, but there are laws prohibiting certain behaviors. Every patient has the right to discontinue care if they choose to do so. In this case, they would be choosing death by choosing to die naturally. The state is not interested in prolonging a life that is all but ended, but the state also does not have interest in ending these lives prematurely. We are suggesting that they withhold care or move them to palliation in these circumstances, not prolong life and suffering. Palliative care would relieve agony and suffering with pain medication and comfort care. It is a much more ethical choice than euthanasia.
In the event that the patient is no longer considered curable, such as a condition like stage 4 cancer, end-stage renal disease, end-stage chronic obstructive pulmonary disorder, it's understandable why some people would think that euthanasia is the most humane option. Euthanasia gives an abrupt end to suffering without the costs associated with long-term care. But is this where we want our health system to go? An era where no value is assigned to life once it reaches a place where the end is near. The points were brought up earlier that people feel like a burden at the end of their lives. But who are we to say that everyone feels like a burden? And why shouldn't they feel cared for? Total human comfort and happiness can in fact be provided, and we have a system in place for this already, palliative care or hospice care. To address the cost factor, hospice works with the family to make their service available to those that need it, regardless of whether or not they can pay. Hospice is covered under Medicare hospice benefit and the Medicaid hospice benefit, and by most private insurers. The physician can fulfill his or her duty to the patient by providing comfort and support at the end of their life, rather than immediate death.
The system would be impossible to regulate. Many questions come to mind when we are dealing with this issue. Yes, 2 states of the U.S. have passed a law in favor of euthanasia. However, many problems have risen from it. Some questions that are brought up include, how do we decide if a disease is incurable? And if a disease is said to be incurable, there are many diseases that can take a lifetime to actually kill the person. There are so many different situations that people simply need time on their side. If you rush this, who says that they could not have lived? How do we regulate so that people do not abuse the system? What if a woman or a man walked into the ER and demanded that they be killed? There needs to be set limitations. This has been tried in Oregon. To prevent hasty decisions, the law requires a patient to take 2 oral requests for the lethal drugs at least 2 weeks apart before the physician can prescribe them. Yet, for the past 6 years, the minimum recorded duration for a patient-physician relationship has been 1 week or less. Not only does this indicate that at least some doctors are not following the law's requirements, but with a median duration of about 12 weeks, it means that most patients are not receiving these prescriptions from a trusted doctor who knows them well. If this is not working for them, it will not work for the rest of the country. The lack of reported complications in Oregon has caused even pro-assisted suicide physicians to question the credibility of Oregon's reported data. Furthermore, the prescribing physicians is not required by law to be present when the drugs are taken. Since 2001, when the data was first collected, prescribing physicians had only been present in 29% of the deaths. The recording of complications is therefore dependent upon the self-reported report of a physician who, in most cases, has not even been present, and who must rely on secondhand information or guesswork to file the report. The Oregon Department of Human Services, which collects the information, must depend on the word of the doctors for the reliability of their data, and it has no authority to investigate individual death and dignity cases. Even more upsetting is the fact that Death and Dignity Act applies no penalties to doctors who do not report that they have prescribed lethal drugs for the purpose of suicide. This means that there is no way to know for sure how many assisted suicide deaths may actually be occurring in Oregon. Nor is there any way to know whether the prescribed drugs are being made available to people other than the patient who requested them. Only 64% of patients who have received the prescriptions are known to have died from taking them. What becomes of all of the other deadly drugs? Is it possible the prescriptions have never been filled? Or maybe the lethal drugs are sitting in medicine cabinets unused. But clearly there is the potential for accidents, and the law provides very little safeguard from abuse. So far, no one has been disciplined for disregarding the safeguards that the law does provide. Complications are not investigated and likely not reported in many cases. And the reality is, DHS has no regulatory authority or resources to ensure compliance with the law. This leads to physicians and insurance companies taking advantage of the system. Will they jump to the conclusion so that they do not have to overpay? Money is very important to healthcare nowadays. If a doctor does a procedure, it is worth $1,500. If he just stays and talks to the patient about the problem, he gets paid $15. Who's to say that the insurance companies won't do anything to save a few dollars? It is much more cost-effective and easier to let people kill themselves, and it can be rationalized as a compassionate approach. One of the primary arguments for assisted suicide is the ending of unbearable physical pain. Experience in the Netherlands, where euthanasia is legal, is revealing. Concern that pain will become unbearable is common, this being a worry in 1/3 or more of such patients. However, the Dutch experience is that of those actually requesting euthanasia, only 5% list physical pain as their major reason, and typically, that when pain is controlled, their minds change. As noted above, loss of autonomy and other psychologically painful concerns are the overwhelming majority of reasons given. Who makes the decision when the patient is unable to? Would a set person need to make this call, just like if a patient needs to be changed from a DNR to a total resuscitation? And lastly, how can a doctor be obligated to follow through with helping a patient die? According to Edmund Pellegrino, MD, director of the Center for Clinical Bioethics of Georgetown University, wrote, "The false promise of beneficent killing that appearance in the 1998 book Regulating How We Die, the ethical, medical, and legal issues surrounding physician-assisted suicide. Quote, euthanasia and assisted suicide are not ethical obligations of physicians. The prohibition against physician participation in euthanasia and assisted suicide has been elemental in the traditional ethics of medicine for a long time. These acts are far from being established morally or accepted professionally. Killing someone by lethal injection is not an act of medicine. It comes from when medicine apparently has nothing left to offer.
Murder is illegal in the United States of America. To make euthanasia legal, we would have to change this law to provide circumstances under which it is okay to murder certain people. One of the 4 common bioethical principles is non-maleficence, or the right to do no harm. By committing active euthanasia, you are unarguably harming the patient and in fact harming them to the point of death. Even if murder were legal, many physicians would have moral issues with being the person to actually have to kill a patient. Can a physician opt to not participate in this practice entirely, or can they pick and choose which patients they feel comfortable euthanizing based on different diseases and prognoses? Again, this is a problem with regulation. This could be a huge area for potential lawsuits. Family members could come back saying that the patient was not in the right state of mind to make that decision, or that they were pressured into making that decision. Settlements and winnings in these types of cases would be immense due to the actual loss of human life. Not only is murder illegal in the judicial system, but it is also against most religious values. It is one of the 10 commandments, thou shalt not kill. Doctors would have to go against this commandment in order to provide euthanasia as an option. Christians believe that human life is sacred because it is a gift from God, and that all human life has value. Therefore, intentionally taking human life should not be tolerated. Christians share this anti-euthanasia stance with most of the other world's major religions, namely Judaism, Islam, Hinduism, and Buddhism, among others. Although they all have differing reasons for rejecting euthanasia, they all agree that it is against their religion. Therefore, there will be many patients and doctors who reject this practice. It is unethical to give patients and family the choice of euthanasia. It is true that some people would rather die than suffer, but it is also true that some people value the sanctity of life and thus disagree with euthanasia. However, if it were a viable option, people may feel guilty or that they are burdened if they do not choose euthanasia, even if it is against what they believe. The cost of keeping someone alive is much more than putting them to death, and someone could choose euthanasia solely to avoid putting that financial burden on their families. On the other hand, families could put pressure on patients to choose euthanasia due to the financial aspects. In these cases, patients would be in a moral dilemma if they do not agree with killing or ending someone's life prematurely. Another possible situation that could arise is family members abusing euthanasia as a means to access their family members' finances sooner, or to ensure that they do not use up a large portion of their finances in hospice or other treatments before they die. There are a lot of cases of elder abuse that are being brought to light lately, and euthanasia is another area where this could be a problem. On the other hand, a patient could choose euthanasia for his or herself and their family would disagree with it or feel guilty about letting a family member choose euthanasia. Most family members who are not experiencing the actual suffering that the patient is experiencing would not understand or be okay with agreeing to actively kill their loved one.
Murder implies malice in that it's against the will of the patient. Is it really harming the patient if you're doing what they want and preventing patient suffering? Yes, the physician's legal obligations need to be addressed by regulation. In Belgium, the law of euthanasia allows physicians to impose further conditions to their participation. In the Netherlands, the Dutch Medical Association has stated that physicians have a duty to refer patients in a timely manner if they are unwilling to perform the service themselves. If euthanasia is legalized, particularly if the legislation is thorough and well crafted, there shouldn't be an issue with lawsuits because the physicians would not be breaking the law. When it comes to the family making the choice, there are things in place called living wills. Living wills and other advanced directives describe your preferences regarding treatment if you're faced with a serious accident or illness. These legal documents speak for you when you're no longer able to speak for yourself, such as if you're in a coma. Advanced directives are well-written instructions regarding your medical care preferences. Your families and doctors will consult your advanced directives if you are unable to make your own healthcare decisions. Having written instructions can help reduce confusion or disagreement. People can include in their advanced directives the choice of euthanasia, if certain circumstances were to be present. This allows for the burden of this choice to be taken off their family members. Although family members may not feel comfortable with the patient's choice of active euthanasia, in the end it comes down to the patient's overall happiness and their choice, which they can indicate in their advanced directives. From a Christianity standpoint, there are examples of euthanasia in the Bible. For example, in 2 Samuel 1, verses 9 and 10, "Then he begged me, 'Come over here and put me out of my misery, for I am in terrible pain and want to die.' So I killed him." Thomas More, a Roman Catholic saint, wrote a book about a perfect society called Utopia, which included euthanasia, where people can choose to die since they cannot live but in great misery. Jesus came so that people could have life in all of its fullness. John 10, verse 10. This means quality of life. If someone has no quality of life, then euthanasia could be good.
It's not impossible to regulate euthanasia. The Netherlands and Belgium have successfully legalized euthanasia, and in the U.S., 3 states, Oregon, Washington, and Vermont, have legalized physician-assisted suicide. The key is to consider what criteria needs to be addressed and do so. The Oregon Death with Dignity law that Stacy discussed was the first physician-assisted suicide law passed in the U.S. The lessons learned and issues mentioned can be used to craft better legislation going forward. The key is to consider all the issues and address them in legislation. Adults versus minors needs to be considered. The Netherlands now allows children over 12 to seek euthanasia, and Belgium is considering whether to expand their laws to include children. I don't think that would go over very well in the U.S., but it just needs to be addressed in legislation. Other criteria to be discussed are: does the patient need to have a terminal illness, or can it be for an incurable disease? What about unresponsive mental illness? Do you want to include incompetent patients in the legislation? Should that even be an option? And if so, how do you protect their rights? Should a family member or an outside individual be appointed to represent their interest? Also, you need to consider, how does a patient request it? Should it be written or oral, or do you need witnesses? Should it be done in an advance directive? Can the patient refuse potentially curative treatment, or must all options be exhausted before euthanasia is considered? Does the patient need a second opinion, a consult with palliative care, or a psychiatric evaluation? What do you do if the family disagrees with the advance directive and the patient is unconscious? All of these are things that can and should be addressed in legislation.
As Deidre said that Belgium is using euthanasia, it was actually stated by CNN. The European Social Rights Committee has condemned Belgium for violation of the European Social Charter because of its lack of social care. It is little wonder that disabled Belgian people fall into terminal despair, but that does not validate euthanasia becoming a treatment for depression as it has in Belgium. So people with depression have taken advantage of euthanasia. This is not ethical.
So we discussed that euthanasia is unethical, but we also don't think allowing unnecessary suffering is ethical either. So the alternative to euthanasia is palliative care, care that's given to meet the patient's basic needs, such as nutrition, bathing, pain management, and other comfort measures. Palliation can be given along with curative medicine, or all curative measures can be removed, such as in hospice care. It's a chance for patients to be well taken care of, perhaps even if they're in their own home, if his or her condition allows. To enter hospice care, a physician must pronounce that death could occur within 6 months if the normal disease process is followed. So this would prevent unnecessarily long periods of suffering and would also prevent an early end to curative treatment. Hospice care is provided as a healthcare team and works to include the family of the patient as much as possible. The goal is to keep the patient as pain and symptom-free as possible while offering spiritual and supportive counseling to the patient and family members. The same support may be hard to come by if euthanasia is legalized because of the care team's personal convictions against its use. The family of the patient may also undergo ridicule and shame from friends or community members for the decision to euthanize, while people with family members in hospice care tend to receive extra support and empathy from their communities. Patients in hospice care can expect pain management, emotional and spiritual support for themselves and family, medications and medical equipment, education for family members on how to provide care, speech or physical therapy if needed, and short-term hospital stays are available when pain or other symptoms are too much to handle at home. So hospice allows the family and the patient to slowly work through the grief process and lets the family be involved in care, but also solidly supported by doctors, nurses, and therapists. It provides an end to radical medical procedures, pain, and suffering, and it allows peace and lets the patient pass away naturally in the comfort of his or her own environment.
Palliative care is not an option for all people, since no amount of palliative care can relieve all distress. Voluntary euthanasia is a reasonable alternative for those who want it. To begin with a familiar type of situation, a patient who is dying of incurable cancer of the throat is in terrible pain, which can no longer be satisfactorily alleviated. He is certain to die within a few days, even if present treatment is continued, but he does not want to go on living for those days since the pain is unbearable. So he asks the doctor for an end to it, and his family joins in the request. Suppose the doctor agrees to withhold treatment, as the conventional doctrine says he may. The justification for his doing so is that the patient is in terrible agony, and since he is going to die anyway, it would be wrong to prolong his suffering needlessly. But now notice this: if one withholds treatment, it may take the patient longer to die, and so he may suffer more than he would if non-direct action was taken and a lethal injection was given. This fact provides strong reason for thinking that once the initial decision not to prolong his agony has been made, active euthanasia is actually preferable to passive euthanasia rather than the reverse. To say otherwise is to endorse the option that leads to more suffering rather than less, and is contrary to the humanitarianism impulse that promotes the decision not to prolong his life in the first place. Advanced directives in palliative care are always welcome. In some, perhaps many cases, the need for assisted suicide and active voluntary euthanasia will be reduced through developments in palliative care. But these developments do not obviate the need for voluntary euthanasia, nor can they control all aspects of a patient's illness to the level desired by all patients. There are still numerous illnesses or conditions for which pain, extreme suffering, and a loss of dignity are difficult or impossible to eliminate. Some patients will suffer the terror of breathlessness or vomit uncontrollably. Others will be choking continuously or unable to swallow. Others will be paralyzed, and still others will be helpless, weak, incontinent, and totally dependent on others. Even if pain and distress are not the major problems, there is often a strong fear of the dependency that would result if all bodily functions, mental and physical, were sufficiently impaired.